I see some new faces, so I'm going to be building off of some of the stuff we covered this morning. So ask questions if we're getting ahead of ourselves or if it's something that you need clarification on. We have about an hour block on PTSD, realizing it's something you're going to be seeing more of in your line of duty as our men and women come home from their tours. What have any of you had encounters with folks with PTSD? And you know that how?
I'm a Vietnam veteran.
Oh, so you know what to look for and how it manifests itself. What about you?
Oh, yeah, veteran.
How many folks do we have in here that have served? God, thank you for your service. Appreciate it. Well, this might be an easier crowd then to talk to PTSD about than I thought. Building off of this morning, we talked about 3 phases of every encounter that you'd have with folks, where you have 3 goals: engage, assess, and resolve. And then we talked about the loss model. All of the variety of situations that you're going to face generally will people be in a crisis that's either a crisis of a loss of hope, a loss of control, a loss of reality, or a loss of perspective. And when we talked about PTSD earlier, we kind of said that one, depending on what you're observing when you come to the crisis, it could fit either of those. You could have someone with PTSD that's suicidal. You could have someone with PTSD that's out of control. And that's really what we wanted to cement this morning, is that loss model prepares you more for the observable characteristics you're going to see and less about the diagnosis of the individual. That being said, there are some special nuances with PTSD that we wanted to cover today. So I'll define PTSD. And again, not clinical. We want to define it by what you will observe, the characteristics of PTSD. And then we'll talk a little bit, now that you've had the EAR model, the Engage, Assess, Resolve model, what does it mean in terms of de-escalation that we need to look at? Why PTSD with CIT? We are good at creating our own language here. It is becoming more prevalent. With the longer deployments and the longer that the conflict in the Middle East happens, we're going to have more and more of our men and women coming home, and they're going to be somewhat damaged by that. That title slide of emotional shrapnel, I like that analogy in the sense that when you have shrapnel, when you have shards of metal in you, usually the treatment for that is to excise it, to find out where it hit and to get it out if you can. With emotional shrapnel, it's a little different. It's in there, but what is it in? And what is it we're taking it out of? We'll see with PTSD that a lot of that with the flashbacks and the memories, that's what we're talking about in terms of trying to excise it with emotional shrapnel. The other reason I like the word shrapnel is it does damage. And with PTSD and emotional shrapnel, it does do damage. Some people with PTSD, including vets, may resist arrest. That's another reason why PTSD with crisis intervention training. Obviously, one of the things you'll want to look for with PTSD, if it's one of our returning vets, they've probably been trained in how to use a gun, maybe carrying. They're going to have training that if they're intent on doing something aggressive or hurting themselves, they obviously have the knowledge and the means to do that. The things you do and say and matter, that's what we talked about a lot this morning. We gave examples of how if you de-escalate someone in a crisis using command and control techniques, how that can actually escalate a situation. And so that's another reason why we're really spending some time with this with CIT. And these are our veterans, regardless of your political background, for the war or against the war. We're there too long, we got in for the wrong reasons. All of that is really secondary to the fact that they're over there and they're coming home, and they're our neighbors and friends and citizens, and we should be there for them, and this is one way that we can do that for them. One of the parallels I want you to think about, and this is where I'll sound more like a social worker, so I'll apologize up front if that's going to be difficult, but when we talk about trauma and PTSD, I want you to think about trauma with police work. When we parallel trauma with what our military vets see and go through and the training they have, think about your own training and your own in the line of duty encounters, because there's a lot of trauma involved with police work. And I don't have the stats here, but I would bet anyone a big bowl of menudo that the incident rate of PTSD for law enforcement compared to the general population, it's higher in law enforcement. I'm going to play just a 1-minute overview. It's a CNN overview on PTSD.
It is a mental condition caused by a traumatic event. Post-traumatic stress syndrome affects many people, but it is more commonly found in men and women who have served on the front lines during combat. According to the Department of Veteran Affairs, many soldiers return from war scared, angry, and confused over events they've witnessed. And if the feelings aren't treated immediately, PTSD can disrupt lives. Psychologists say the stress of war can be so great and the emotions so intense that changes in the brain can occur, causing the military personnel to relive terrible events, avoid their loved ones, become completely numb to emotion, or always seem anxious. These symptoms can lead to drinking and drug problems, depression, employment issues, as well as divorce and domestic violence. The VA recommends that if you know someone who's suffering from PTSD, have them seek professional help. There are good treatments for PTSD, especially when it is diagnosed at an early stage. For today's Health Minute, I'm Alyssa Long.
Right, for a 1-minute video on PTSD, it really did cover a lot of the basics, and I want to just expand on some of those. What PTSD, the symptoms, what it feels like to the person is, it's hard to explain, but they feel like a shadow of their former selves. The trauma that they experienced was so deep, they feel diminished, they feel helpless. One of the vets that has PTSD that was talking about how it affects them in one of the other training videos said, I know I love my family, I know I love my kids, I don't feel it anymore. I mean, I know up here I love them, but it's been so long since I felt it. There's a real vacuum that they have, that the trauma has incurred in terms of their emotional feelings. And I wanted to kind of just clarify with PTSD, we have to have 3 things that happen. This is not the same as anxiety. It's considered a diagnosis in the anxiety spectrum, but this isn't just your run-of-the-mill anxiety. Something real has to have happened. Now, obviously, that seems obvious, but when we talk about earlier, when we talked about loss of reality, some folks are dealing with folks that aren't things that aren't real, hearing voices and seeing things. With PTSD, war, trauma happened to them, and their response to that, they're haunted by it. Not everyone, and we'll talk a little bit about why is it some people get it and some people don't, but their ability to deal with that trauma is diminished, and they're haunted by it, and that creates a set of symptoms that clinicians can then begin to look for, diagnose, and begin to treat. There's actually really good treatment for this. Cognitive behavioral therapy, CBT, is what's listed up there, is one. So is exposure therapy. They're doing a lot now with technology and gaming, where they're putting vets right into the gaming units of some very realistic simulated wargaming, where they're trying to put them right back into the situation that evoked the trauma in a very safe environment, and in an environment where the vet can still control it. They can stop the stimulation or the simulation at any point, but they call that exposure therapy. Sooner or later, a common ingredient with all the therapies is to revisit the trauma. It seems to really heal from this and to be able to reclaim your life back. That's one of the key ingredients. You know that someone with PTSD, or we know as clinicians that someone with PTSD is healing and getting better when the episodes are impacting them with much less strength, much less frequency, that they have their own coping skills. It begins to them, another vet explained it as, think of the worst headache you've ever had that comes on when it wants to. It comes on without warning. I can't take aspirin, or I can't make it go away, to the healing of, yeah, I get an occasional headache every now and then, and I can take aspirin and the pain goes away. Part of the treatment is integrating the sense of self, the sense of control back into their lives, and the good news is recovery is possible. All right, I'm going to spend a little bit of time on how we think about all of these disorders, and then specifically PTSD. And this, what I'm going to show you, is going to be true for almost all of the different diagnostic categories that will make up the special encounters that you have in law enforcement. When we think about diagnosing, we like to start with saying the concepts of health affects everybody. A smaller group of people will get sick. So health and illness fall on a continuum. What decides whether or not you're sick usually is the duration and intensity of your symptoms. The duration, how long, the intensity, how frequent. So if I have a headache, a cough, or a fever that comes on and I take aspirin, I rest, the duration isn't intense. I don't have a lot of issues with it. I could take the aspirin and the headache's gone. I can take some cough syrup and the cough's gone. Then we don't really consider me ill. So these are normal symptoms. We all will have these headaches, coughs, and fevers. It's when the duration intensity starts to grow so that my headache, the duration of my headache is I wake up in the morning with it, I can't get rid of it. You know, it's 6 straight hours of the splitting headache. And the intensity is just that, the depth of the pain, how much of it is. So it's much different than I woke up, took aspirin, it's gone, or I get a headache once a month, versus I have these migraines. So that creates a set of symptoms that a doctor can look at. And it's the same with all of that. When we start to think about, say, depression, again, there's a normal set of symptoms where we would all feel sad depending on what's happened to us. Some related symptoms to depression: tiredness, irritable appetite. The existence of those by themselves doesn't mean that we have a depressive disorder or that we could be diagnosed with depression. It's the duration and intensity. And the clinical manual that looks at all this stuff actually has kind of a recipe that the clinician follows based on duration and intensity. So to treat adjustment disorder would be different than major depression based on the duration and intensity of the symptoms that I'm displaying. Obviously, major depressive disorder is someone that's more often very deeply depressed. It's not situational. It's not grieving over a loved one. They actually spell out timelines in the diagnostic manual. So just as health and illness fall on this continuum, where we all have normal symptoms, the duration and intensity are key. And it's the same with stress. Stress on a continuum, normal reactions that we have in stressful situations: difficulty concentrating, helplessness, nervousness, those are all normal. Those by themselves don't mean that anyone has any sort of disorder or issue. As we go further down with duration intensity, that's when we get a set of symptoms, again, that we can start to diagnose. The thing that's different about PTSD, though, is it takes a traumatic event. And that's what sets it apart from, say, just a acute anxiety disorder or a generalized anxiety disorder. I could have a fear of driving over bridges. I could have panic attacks. All of those can happen and develop without a traumatic event happening to me. PTSD is a response to a traumatic event. So that's one of the big differences as we conceptualize PTSD. And what is trauma? I mean, it's not always what we see our sons and daughters in military see. It could be abuse, incest, rape. We talked a little bit this morning about trauma, and the Idaho program goes into trauma that some of our families are going through and living with abuse and domestic violence. Seeing violence, murder, victims of violence, war, all of these is what constitute trauma. Natural disasters. Our home community in Findlay in 2007 lived through a flood that made national news. It was the worst flood that we had in 88 years. A lot of devastation downtown, a lot of devastation in some of the subdivisions that were farming fields that they just put houses on. They were actually low-lying areas that were natural basins for collecting water, and we didn't think anything of raising the ground or anything. So there was a real lot of devastation from that. All right, this is another video from The U.S. Army created a website called battlemines.mil, I believe. They have created a very good series on PTSD for returning vets and their families. And this gave a little bit of an overview of some of the stigma associated with PTSD.
Over here, probably at your 1 o'clock. Just ground.
Many sleepless nights, depressed days. I would sit in one spot most of the day. I would isolate and I wouldn't go out. I wouldn't talk to anybody. I wouldn't answer the telephone. I was still skeptical about getting help. You know, when you mention the word mental health, behavioral health, there's that stigma. I look at it from a more wider perspective, from the standpoint of that as long as we're wearing the uniform, we're going to feel safe. And that stigma's going to always be there. You know, we look at things such as, okay, I'm worried about what my leadership might say. They might look at me in a different, in a different way. I might lose my security clearance. But at the same time, from a leader standpoint, this also affects the readiness of the military, the readiness of the units. So there's something we have to do to be able to go out there and pull that stigma back for the soldiers and for the leaders, period, all around. Understand, learn about post-traumatic stress disorder, learn what the symptoms are, you know, learn how to cope with it, because for soldiers out there now, the majority of them, if not all of them, have been through that theater over there, or going through it, or been on 1 or 2 or 3 rotation. So they kind of understand. So talk about it, get it out on the table, you know, and then, hey, once you get it out on the table and you feel much better, you get the help, and, you know, you can kind of move on a little bit.
So common with PTSD is you have to have a trauma, and it puts persons having to go through profound transitions just to try and reclaim their life back, to try and deal with that trauma. Like we said earlier, the memory basically attacks you when it wants. The CNN video mentioned that it does change the brain a little bit. The relationship to trauma in the brain, we're not really sure. We know the hippocampus is a part of the brain that's really, really affected by trauma. One of the things they learned early on is in folks with PTSD that have experienced a major traumatic event, they found that the hippocampus was smaller than someone that hadn't gone through that. At least that's what they were conjecturing. So they were trying to figure out, did the stress cause a decrease in the size of the hippocampus, or did they have a small hippocampus to begin with? They answered that question by doing twin studies where they had identical twins, some who went to military and had trauma and their twin didn't, and were able to find out that both of their hippocampus were small. And it really kind of made them reframe how they're looking at what causes these issues. It's not an excuse, I guess, to kind of say for someone that is dealing with a bad situation that they need the fortitude, they need the strength, they need the character just to get over it, because there are these brain changes in here. If you were to ask me what causes mental illness, I could not answer that, nor can anyone with a lot more MDs and training behind their name than me. What we've done is taken that question, which we usually do in science when we can't answer, and ask a different way. What do we know that correlates? What is related to mental illnesses coming in? And it's that whole nurture versus nature. We know, and I talked earlier this morning about the MRI scans of folks with schizophrenia. They've also done physical scans of the brains, and they have a smaller temporal lobe than the normal person. And they know that that temporal lobe's connected to ways that we process information. But all of this is kind of just putting the puzzle pieces together. But you could see the nature part being biology and heredity, genes, brain chemistry, brain structure, plays a role in this. Certainly, so does nurture in our environment. Extreme stress, if you add on top of that lack of coping skills, possibly lack of support, stigma, it just means that there's a camp with a predisposition to certain vulnerabilities and overwhelming stress, and when those kind of come together is where mental illness lives. So that previous picture is more, it's not an excuse, it's not a reason why someone can't, quote, snap out of it. We really do understand that it's kind of this relationship between nurture and nature. When we were first learning about depression, doctors thought that it was event-driven. It was situation-specific. You got sad because something happened in your life. It wasn't until that they were finding out there were patients that were depressed, and when they were interviewing them, it wasn't event-driven, it wasn't situation-specific, but they were depressed. I mean, if you took the blood and you looked at the blood levels, they had the same type of depression, if you will, than someone that was responding to an event. And so it really changed their thinking of it being event-driven, meaning environment, to something else that might be going on there as well, biology and hereditary. Certainly depression has those components to it. For our CIT training, obviously, we can't do a whole lot with the genes and the brain chemistry and the brain structure, so what we focus on is what we can, which is the stuff that's in the environment. This is a page from the DSM, the Diagnostic Statistic Manual, that looks at acute stress disorder. This is kind of an example when I showed you the continuums of how they itemize duration and intensity. You could see a minimum of 1 in terms of under the re-experiencing of it, which is both in acute stress and post-traumatic, but the two columns show you how it moves to more severe and of longer term when it's on the PTSD side. But to be honest, I don't want you to spend a whole lot of time with the diagnostic criteria because that's not what you observe in encounters. That's what we want the CIT to focus on, is what does PTSD look like, and then what do you do with that from a de-escalation standpoint. This morning we talked about the loss model, and we talked about the loss of control and loss of reality, the loss of perspective, and the loss of hope as a way that are the observable characteristics that all of the encounters you have that fall under the guidelines of special populations will make themselves known to you by looking one of these 4 ways. And it's true with PTSD as well. We talked about which box does that best fit in, and we said we don't know. It depends on what you're observing. It depends on what you're seeing in the encounter. Just a note about civilian versus military PTSD. Obviously, there's some differences. We're exposing, while the training is better for our troops, we're obviously exposing them to a lot more trauma than a civilian might be exposed to, because that's what war is. So they have to wrestle with the whole transition from wartime to peacetime. And that's where we see a lot of this, is that transition. And that Battle Minds program is an excellent program. The word Battle Minds is an acronym, and each of the letters stand for something that the officer got as part of their training that kept them alive, that they needed while they were over there. The B in this case was buddies. How buddies have your back, how you're watching out for each other, how you're vigilant in a wartime situation. And then when you come home, what happens to that skill or that category when you're not in war anymore? And in this case, the Battle Minds was saying when you start, all of your friends were wartime friends, and when you transition back, that's a tough transition for some of the vets to make. And so the whole transition is what really starts to put a magnifying glass, because we prepare them well for wartime. We don't prepare them well to dial it down for peacetime. The battlefields of war and the battlefields at home obviously are very, very different. If we were to think about PTSD and you responding to a suicide call, again, the worst case scenario, we'd have a vet that has means, has access, knows how to use weapons, So if they're intent on killing themselves, it's a lot different than a civilian suicide, where they might not have that training on arms and weapons. And de-escalation, and we'll talk a little bit about the de-escalation. This morning we talked about 3 phases of every encounter that you'll have with special populations. Your goal is to use your communication skills, your de-escalation skills, to engage so you can assess, so you can resolve. So if we're talking about someone with military experience, it's great to ask them as an engagement strategy about their experience, if they're willing to talk about that. If you come upon someone and you could tell by the way they're dressed, if they have military garb, they offer that information, talk to them about that. Ask them what they did. Ask them, where they served. That could be very deflating for the vet to talk about their experience. Now, if talking about it makes them anxious, it's not something you're pulling out of them. It's if they're offering it freely. If you've served, that's a great engagement strategy as well. If you know that you're encountering someone that has had military experiences, to share what you did as your military experience too. Certainly thanking them for their service isn't a bad engagement skill either. Gather the information. Again, if it's someone with training, just be wary that they have had training. And if there's a weapon involved, you're going to need to disarm them. If you're past the engagement phase and they're talking to you and they're opening up a little bit more, if they're telling you about their war experience, it's okay. Now, again, we're not asking you to diagnose PTSD, but the big kind of crowning characteristic with this is the flashbacks, is they're reliving that. Go ahead and ask that and see what they offer. Be mindful of alcohol and other drugs, or depression and suicide. PTSD by itself rarely exists. It's almost always commingled with a diagnosis of depression, and the way sometimes folks cope with that is alcohol and drug use. So it's very rare that we just have someone with PTSD without other things going on. So for your assessment phase, just make sure you're ruling some of that in or out. And certainly depression and suicide is something that we're looking at. For the resolution phase, again, voluntary compliance is what we're trying to get. You really can establish a sense of hope in terms of trying to get them treatment. You're going to get knowledge. You have knowledge of the mental health system. You're going to get more of that tomorrow. But that's really critical, that they understand that you're there to help, and that you could begin that process today with them as you're de-escalating them. Let me talk a little bit now about the parallels, not between civilians and military, but law enforcement and military. Both of you have what's considered a line of duty. You're trained to react at a moment's notice, to make split decisions. Adrenaline surges, and you face trauma in your line of work, whether it's shots fired, whether it's shots fired at you, whether it's the trauma of child abuse that you're involved in witnessing and seeing, whether it's the trauma of major injuries, car accidents. You have a lot of trauma in your chosen career. In the culture of the armed services and law enforcement, rules and hierarchy are important. They save lives. They make communication work that much better when there's rules and hierarchy. Your partner has your back. Those are 2 very strong parallels with military and law enforcement. And really, emotional weakness, it's really not tolerated. It's something that could get someone hurt in terms of the culture. Training of armed services and law enforcement, obviously your use of weapons and your condition to survive, which is why the training works. With those parallels, I want you to, there's another website that was created. It's called Badge of Peace, I believe. I think it's on here. It's a website that was created for law enforcement, and this is a little snippet they have about law enforcement and PTSD. Look, I don't care if you see a therapist once a year. I think to talk about trauma and stress without looking at what you go through, I'd be remiss because, you know, it's really critical, I think, if you need help or if your partner needs help, to be able to fight past the stigma, to be able to still work in a culture maybe where all of the things that that gentleman said about the military, would I be passed over for promotions and special operations? You know, that's your individual decision. I'm just saying that if you or your partner need help, whether it's seeing a therapist, just be able to take care of that. The thing with CIT is being able to recognize in these encounters what these medical conditions are. And with the military experience and the law enforcement experience, we are putting you at a higher risk by your chosen field for trauma and stress. So I always feel like I learn so much more when I come to these. Thank you. I appreciate it.